Good afternoon, everyone. Thanks so much for joining our joint webinar today with X12. We're really excited to bring you part 2 of our claim attachment transaction and operating rule webinar. If you missed part 1, no problem. We'll send that link out when we send a recording of the slides from today. But really, we're hoping to just go into a deeper dive from our first session that we held a bit over a year ago. Before I go through the agenda, I'm going to run through some quick webinar logistics for everybody. Today's session will be recorded, so anyone who attended or registered will receive an email with a link to the recording after the webinar. As an attendee, your microphone will be muted. However, we do encourage you ask questions throughout the session. And so if you think of a question, you can go ahead and submit it using that Q&A feature at the bottom of your screen at any time. All right, so with that, I'd love to pass it along to our speakers for today. We have wonderful guest speakers who are going to have an engaging discussion for you all. I'm going to let them each introduce themselves, starting with Michelle.
Thank you, Jackie. Welcome, everyone. We're so excited you're here today. I am Michelle Berry. My role is from an X12 liaison to core, and I am here to support this panel discussion in any way possible. So, Crystal, I'm going to go ahead and turn it over to you.
Thanks, Michelle. Hi, everyone. I'm Crystal Green. I work for Elevance Health, and I work within the eSolutions division as a senior business consultant advisor. And my role is an industry lead for Elevance. So I work very closely with CAQH Core, X12, HL7, and others. And I did actually work on the main project to implement the 275 here within Anthem and Elevance Health over the past, we probably implemented that about 5 years ago. So that's my expertise for this meeting.
Great. Now, Bob Bowman, I'm the principal for interoperability and standards at CAQH Core. I've been here for almost 17 years or 18. I can't remember now. The numbers keep going up. Can't remember them all. I've also the liaison with X12. I'm also on the board of directors for WEDI, so in this space for quite a while. And welcome everyone for our discussion today. With that, I'll hand the call back over for a review of our agenda.
Great. Thanks, Bob. All right, so I'll walk through our agenda before I pass it along to our wonderful speakers. First, we'll go over just a brief overview of X12 and Core to orient anyone who might be new. And from there, the bulk of the presentation today will be a panel discussion that really answers some of the most pressing questions that we've seen from industry around the attachments transaction over the past year or so. And so we're hoping to address, some of those FAQs. If you think of any questions as this panel discussion is going on, please feel free to send them over to us and we can help answer them live. We'll close out today by giving a sneak peek of a study that we've done on electronic attachments that really evaluated the impact of implementing the transaction and operating rules in real life. And so we're excited to share those findings with you today. Lastly, we'll have audience Q&A for any lingering questions that you all might have, and we'll wrap up with a brief call to action before we sign off. And with that, I'm going to go ahead and pass things over to Michelle, who will walk us through that brief X12 overview.
Thank you, Jackie. If we can go to the next slide. Couple of things I want to share with everyone. Exciting times we're in right now. We're going to be really discussing, Crystal and Bob specifically are going to be discussing electronic attachments. Right now, I'm going to give a high-level overview of what's happening around X12 and electronic attachments. So if we could go to the next slide. Couple of things. Super important from a logistics perspective. First of all, this is a presentation based on information at time of the presentation for informational purposes. And again, it's not intended to represent any legal advice. Again, just point in time communication. Next slide. X12 is based on ANSI accredited standards or consensus base, a nonprofit organization. If you think about the focus and the intent and purpose and the background is really derived from an X12 diverse membership that comes together often in standing meetings and internal or interim meetings that really bring together those technologists, clearinghouse vendors, health plans, payers, and organizations to address updating, modifying, creating business standards based on the experiences that we currently have in the healthcare industry. When I say healthcare, X12 is more than just healthcare. It's more than just dental vision. It's insurance, proper meaning, property and casualty. It's also transportation and finance and government, supply chain. So X12 has many facets and organizations, structures, and again, organizations that report into X12 organization. Some of the standards that we talk about, specifically this one, electronic attachments. Attachments are super important when you need additional information to support that particular transaction. Again, we've been in this organization from an EDI perspective for over 40 years. So you can imagine the amount of experience across all of X12 proper, but specifically focusing on the 275 electronic attachments and how supportive this transaction is, or how important this transaction is in the industry for a multitude of reasons. As I stated, the first one is attaching or providing additional information to support an actual transaction, care event, if you will. The next slide. Additionally, X12 and our goals and why standards are important. Keeping in mind, we have different individuals, as I stated earlier, that come together. They're vested constituents, members who genuinely have and understand the industry and are providing recommendations as to how to move forward with transactions. And again, it's based on current state, future state. It's not just what is happening right now or what has happened in the past. But again, making sure this data, this transaction, the standards are the bones of communication, transparency of the communication, making information more accessible. Again, this is very important for us to continue our conversation. And I'm going to go ahead and turn it over. If we go to the next slide, our panel discussion. Bob, next to you.
Great. Thanks, Michelle. And right before we get into the panel discussion, just a couple of quick slides on who CORE is, what we're doing, and why we're in this space, and actually why attachments. Why do we write these rules for attachments? As you know, on the next slide, you'll see that CORE has over 100 participating organizations that work together across industry, across stakeholder groups to come up with, not only do we identify the problems, but we also identify the solutions. And many of those solutions are based in operating rules because we have significant investments in technology. We have significant investments in standards and standards development across the industry. But we have to bring all of that together to really serve the business purpose. And so we have developed a number of sets of operating rules, 10 of which are HIPAA mandated. And because of the success of the implementations that you, the stakeholders, do through time, we've been able to track over $46 billion in savings because you have implemented the operating rules. On the next slide, you'll see just how pervasive the operating rules are. Almost no matter where you're at in the revenue cycle, there's probably a set of core operating rules that have been developed by you, the participants. Everywhere from the eligibility transaction all the way through to the payment of the claim. So if you are struggling with where to implement this solution or where to implement that technology or what trading partner to onboard next to help with this, that data exchange and the data and the accuracy and the quality of the data are all important. There's probably an operating rule designed to help. So again, we're focusing particularly on the claims attachment today. And on the next slide, you'll see that since we published our rule in 2022, again, get my dates messed up here. So been doing this for so long, right, Crystal? We've actually seen some significant improvements with plans, both on the medical and dental side, adopting electronic means to exchange attachment transactions and attachment data. From the latest issue of our core CAQH index, I'm sorry, the CAQH index, you'll see we've got an increase from 24 to 32%. We've seen the fully manual drop from 76 to 68%. For medical, an increase of 6% over the last 2 years. For dental, another 6% decrease in the manual. So again, we're making the numbers right for folks to implement, again, a standard with operating rules to really customize the business needs, whether it doesn't matter if you're in medical, whatever that silo is in medical that you're in, or dental, and how that is improving your business processes. So with that, we'll move into our panel discussion with some questions that we have received both from the registrants who have registered. I'll also maybe pause now or two that if you have any questions that come up that you already have and you want to put those into our Q&A box, please submit those now. And as Crystal and I go through the discussion, if something piques your interest or you have a question, go ahead and pop it in the Q&A box as well. And we'll try to address as many of these as we can through our discussion. Jay, I want to make sure I set that up okay. I think we're ready to go probably into our industry questions. On the next slide. And I'll start, Crystal, and just say that these are the big topics that have always come up, I think, when you talk about attachments. And one in particular is reassociation. This is really significant, whether it's solicited or unsolicited. The industry has maybe traditionally been challenged with reassociation. And there are mechanisms within the transactions themselves to make that reassociation work. Can you maybe walk through what that means in a standard way?
Certainly. Again, right, we're talking about claims. There's also prior authorization transactions that we have to reassociate the documents that come in or the electronic attachments. So for the 837 claim, there's a segment called paperwork included, which is a PWK segment, and that's in the X12 standard. What we do is we educate our provider community this is a voluntary segment, of course, but if they're going to be sending in documentation to use that segment, that will actually document a tracking number. We ask for Anthem and our commercial and some of our government business, and we have some of this language also in other guides like the Attachment Collaboration Project guide that you can find out on the WEDI website. It was WEDI X12, and I think even HL7, we came together to put together some information around electronic attachments. It tells you how to reassociate the PWK, which is the 06 match of the attachment. It has a number that the provider will provide. We ask that the provider, and it doesn't always come through this way, but have a PWK in front of the number. We just give some advice if they want to do PWK, for example, maybe the patient account number and the date of the claim. That would be a way that they could always kind of track back to what that claim and that attachment was. So for unsolicited documents, there's two types, and I don't know if we're getting into that or not, but I know this is the reassociation. We would be sending out for a solicited, the payer would request, because we already received the claim without documentation, we would request supporting information from the provider, which we will include our claim number as the attachment control number. And then the provider will be able to return that information to us with the patient name, member ID, billing information, data service, along with the attachment control number with the attachment, so we can match it back up as it comes in on the 275 to the claim that we already have in our system. Sometimes when submitting additional documentation to support a request, it could be like medical records or, a discharge summary, depending on what it is. That unique identifier really is used to correctly match that up. That's very important. We've had some lessons learned over the years when we implemented. What we found was some providers will use a certain clearinghouse for claims or even their practice management system. However, for electronic attachment, there are major clearinghouses like Japari and others that strictly work with electronic attachments. And what we were finding in our testing and when we were first trying to implement about 5 years ago, that the number that was being sent on the claim in the PWK was not matching what was being sent on the 275, which of course you could see is an issue because they weren't matching up in our system. So there was some education that we had to do around that. And again, having that guideline on how you document that PWK and send that in on the claim and then follow with the 275 with that same number is very important to us. So I don't know if you want to add a little bit more to that, Bob,
Yeah,
but
definitely.
I
Yeah, I
mean,
think
we
you bring
also
up,
have the 278, which is I guess I should say what we're doing. For the 278 transaction, which is the prior authorization, we also are using the PWK segment in the 278 to ask the provider for specific documentation so we can get that information back so we can process that quickly. So again, it's another PWK segment that is also used for the X12 278 healthcare services review information. We are also having that in play today. We definitely receive a lot more of the claims attachments than we do the prior auth at this time, but we are doing it with both. We also have a dental, not only our medical, but we have our dental 275s coming in, which is pretty significant for dental. I think you could see that on Bob's slide that he had just a couple slides ago. Dental's a little bit farther ahead than medical and percentages wise for us in sending electronic documentation.
yeah, maybe I think you said a couple things that I maybe want to key off of. One is the importance of the PWK and what appears in the PWK and how that helps reassociate the transactions. And the data that is returned by the provider. And in the core rules, we call them common reference data. Here's a set of data that really can help reassociate that attachment with the claim, or in the case that if we want to extend it to prior authorization, some of these data fields don't match in the PA. That's maybe a separate discussion, but the claim number, the control number, the date of birth, date of service, member ID, member name, the patient control number. There's a set of data in the operating rules that allow providers to, if you include this, it increases that chance of matching to the claim exponentially. So it's really important that providers, as they implement not only the standard, but also the operating rules, that they understand that the robustness of the data, either that you're sending or that the health plan is receiving, can really help improve that reassociation. I think, Crystal, too, you mentioned something that's important related to working with your provider community to make sure that they're educated. Not only are venues like this helpful for that, but really digging into finding those issues and solutions and bringing them to the larger community like a WEDI or like a CAQH core for industry education is really important. Maybe a quick question too. What version of the 275 have you implemented? Is it the 6020? Is it a previous version? Is it a current version, 8020?
Yeah, what we've seen across the board is either it's going to be 5010 or 6020.
Okay.
We at Anthem went, and this is Elevon's Health now, but with Anthem and our other core business, commercial and government business, we went with the 5010 just to keep in alignment with all the other transactions that we have in 5010. We thought it'd be easier on the providers not having to do a different version. Though some of our documentation, as I was mentioning, and educational materials that we put out from the industry, like the ACP guide that I was just speaking to, did recommend the 60/20 because we were at that point. And again, it's been years that we've been trying to get this rule passed. Back in, gosh, 2015, we met with NCBHS, many of us, supporting 60/20, trying to get that rule passed. So we were going to move to 60/20. However, again, the regulation's always been stalled. It's really not moved forward at this point. It's still sitting out on the federal agenda, the unified agenda, and we watch it twice a year, but it's still sitting there. And one thing where we're at now with that is it's still stating 60/20, and we're actually farther along now with X12 than that. So, at this point, we may have to withdraw that request because that's back from 2015-16 timeframe and move to a newer version, just so you're FYI on that. But again, most people are either on 50/10 or in 60/20. We do have a government business NGS also under the umbrella of Elevance Health, and they did go with the 60/20 right off the bat. So I just wanted to share with you on that. Little differences, but not major. But either of those two transactions today are being submitted by providers.
Yep, and I will add that the core participants, we drafted our operating rules with the version 60/20 in mind. So again, it could be applicable to any of the versions basically, because the rules are specific around the PWK, which is kind of universal within the transactions, the reference data, which is universal across the versions of the transactions to make it a little easier. So if you're on 50/10 or if you're in a more contemporary version of the 275, the rules will still be applicable. So you can still use those reference data, the PWK reference that we have, the infrastructure rule that we have published, it's all still applicable. And again, can facilitate expedited implementation of the 275 because you know exactly what to expect with the data coming in. You know how to build those reassociation structures. I think another important component to the 275 is this next bullet, the clinical documentation formats. What is allowed in the 275? What do you do? How do you accept all of these versions today? Does Elevance do that, or do you bring it down to
We
very
have
specific?
specifics, and that varies. And I was going to bring up too that the vendor clearinghouses also support both 50/10 and 60/20, depending on what the provider or the payer wants to receive and send. So I've seen, speaking with our vendors, they will support both, the ones that are doing attachments. So I just wanted to share that. But for Anthem, we started with PDFs, TIFFs, JPEGs. For dental, I think we're getting those also, possibly DICOM, but we weren't doing the consolidated CDA format. Our NGS side that I had mentioned, our contractor, Medicare contractor, they do CDA, CCDA. So it's across the board depending on payer, on what they're receiving now. And we know as things move forward, we're hoping that we can accept any type of transaction. But like we said, I mean, it can be a PDF, it could be a picture of something, it could be a consolidated CDA, it could be a fire bundle, whatever. But, really looking for the future with X12 to be able to support any type of documentation that the provider wants to submit to us. We'd love to have it structured at some point because structured data is either easier to bring into your system and really use the pieces and parts of that data that you need. Again, we can reuse that data too, instead of requesting again from providers the same data that we already have. So we're looking forward to that for sure in the future.
Yeah, I think that's a good point that the standard allows for a wide variety of potential. And that potential is helpful because it meets the market where it's at today. It helps providers, the lowest common denominator, wherever they have. If it's PDF, if it's a JPEG, a TXT file, they can use it, right? They can get the data into that plan for them to help adjudicate the claim, or, as you mentioned, even prior authorizations. But as maybe the technology advances or as systems advance, we can get into more of that structured data to make it easier for health plans to identify this key specific data that's needed to resolve the PIN, to resolve the prior authorization PIN, and help the provider more specifically identify that unique piece of data that's needed rather than the whole file or then the entire report that's kind of holding up the adjudication. You mentioned also that you send back a request, maybe in a solicited request to the provider. The current operating rules, we suggest using a LOINC code to do that. Hey, we need this really specific thing from you, provider, to send in, because that's what we need to interrogate against to remove the PIN on the
Yes.
claim. Do you have guidance for LOINC codes, or is there some
Yes.
other mechanism that you use to notify the provider of what's actually needed?
LOINC codes are very important to us, not only for us requesting, but when providers are sending in even an unsolicited document, so we know what it is.
Yep.
LOINC codes can, if you're not aware of LOINC codes, they have been also documented to be in use for the X12-275. You can go to loinc.org. Regan Streif is a company that updates the LOINC codes, just a little history around it. We have also what's called a HIPAA tab. The HIPAA tab is tying back to these 275s. We asked for a HIPAA tab for LOINC codes because there's hundreds of thousands of different codes within the LOINC system, laboratory. I mean, you could just think of all the cancer type codes. We wanted to be able to make it easier on the provider community if we had a subset of codes on the LOINC that us as payers would be asking the providers for. So we have a list out there on the HIPAA tab. It's probably about 100 codes right now. Things that we would normally be asking for, discharge summary, physical and history. Maybe we need the office note. So the major things at a high level, we wanted to add to the HIPAA tab so that the providers would know exactly what we're asking for and what to send back, but not overwhelming them within their systems to have to carry, 200,000 codes that they may never use, and they have to keep updating them because the LOINC codes are updated twice a year. So the LOINC code, yes, is very important. The most common LOINC code we see coming in, especially on unsolicited, is pretty generic. It's called a medical record, and it could sometimes be anything because they didn't code specifically to the other types of documents. But we'd love to see more people really using what documents that they're trying to send us to use the right LOINC code, and that's why we always update when needed the LOINC tab, the HIPAA tab that I was speaking to. But the I think it's 11503-0 is the LOINC code for medical record, and that's used a lot, especially in unsolicited documentation. But for when we solicit, we may say, okay, we need the maybe the provider's license number, maybe something was wrong on our side for that, but we also need to have the office notes or whatever it was for that service. So we'll do the specific LOINC codes for those two, telling the provider what to submit to us. And then they normally will send those same LOINC codes back within the reassociation of the documents coming back to us for the claim or for the prior authorization. So yes, they are very important, Bob. We use them, we educate around them. The HL7 work group, the payer provider information exchange work group are the ones that are responsible for keeping that HIPAA code updated, the HIPAA tab updated. I'm part of that group. I'm one of the co-chairs on that group, along with Karuna Rawani from Blue Cross Blue Shield Association, Chris Johnson from Blue Cross Blue Shield of Alabama, and Mary Kay McDaniels. So very important. If anybody ever wants more information, we can give you some information or even do a session around LOINC. We have, tons of information for you if you need it.
So let me just summarize quickly what you said. I think that's really important for our audience today is that the LOINCs and their use are really important in identifying the specific documentation type that might be required for removing the pin on the claim or just supporting the claim. And that the more specificity that you can drive down to the LOINC code can be really helpful. So if a health plan can identify the specific document by that LOINC code, it helps the provider match that and get exactly what's required. And it would also say that specificity allows for more automation, right? I'm going to maybe take this to the next step. That if you know exactly that this is the type of document that's going to be coming back from the provider because you, health plan, sent this link as the request, then that can actually be put through a workflow to specific representatives that work those types of claim pins or edits. They're only going to send these types of LOINC codes out. They're only going to get these types of attachments back in. So you can really specialize your claims adjuster, the people who work your claims, to that level of specificity. So they can build up skill, they can work these more quickly. You can actually automate this eventually with AI, right? I mean, there's ways that when you have standardized data, and uniform processes, it builds automation. That's the foundation of automation. So a little high horse here, but that data is really important. The specificity of the data is really important, and the LOINC codes help drive that, especially in this process. So maybe we'll move on to the next topic.
Just maybe one more thing on that, Bob. And yeah, you were right for the specificity, because we could send, let's say, for example, we need a progress note, right, to the provider. He could be more specific. Instead of just sending that code back, he might say, this is for rehabilitation progress note, which there's more codes. Remember, I was saying behind the scenes, but we try to keep it clean. So we have just certain codes that we'll send them so they don't have to have everything in their system. But we expect those too sometimes when they're being more specific, which is great. I mean, so really we know that was for the rehab, and we're glad they sent us that. So they can, send other codes, not what we sent them. It could be more specific.
Yep. And I think maybe thinking a little bit in the future, but as the industry adopts the transactions and the operating rules and the LOINC codes, it makes this process more seamless. The operating rules and the standard can evolve with that too, because you're going to find more business needs. Oh man, there's always this mismatch that we're getting between what I request and what the provider sends. Well, how can we close that gap? It could be with making the standard a little tighter, turning on this lever, turning on that lever, making something more specific, or an operating rule can do the same thing, right? Hey, these two things need to match up better. We need to improve this. So it goes along with your point earlier that provider education goes a long way, but if we can actually tighten up the standard and the operating rules together, it can really help the provider as well. For those that maybe are in the know, right, and don't stay engaged with the industry education that we promote so much. Maybe moving on to acknowledgements. A provider sends in an X12-275. What should they receive from the health plan? How do they know it's not being dropped off in a black box?
Well, for us, right away, we send back a 999. And if there's any issue within the transaction, we will point that out to exactly where the issue was with the 275 that they submitted us, so they can get it fixed, correct it, and send it back in. We also sometimes will receive it and the transaction looks good. And let's say we get the document internally, but it's corrupt, right? And so at that point, then we will send something to the provider. We normally will do it through our provider portal, because most of our providers are on our portal all the time anyhow, to let them know that, we had an issue with this document. We need you to resubmit it. So we have that. But other than that, if it comes in and it's a good document and we do process it, still at times it may not be the right document that we asked for. We use the old cat scenario. Maybe we got a picture of a cat, but we didn't want a picture of a cat. We wanted the progress note. Then we will contact them sometimes through either a letter or through the portal, or even just through a remittance advice to tell them it wasn't, what we needed. We can't process this at this time to get that resubmitted.
And again, this process, maybe to expand upon the next step in the process, right? The provider sends in the attachment, you send back the 999. You're processing and adjudicating that attachment. you're matching it up, reassociating it with the claim. Now the claims adjuster can, or associate can work the claim, potentially remove the pend, or wait, maybe the attachment was the wrong one. So it has the opportunity to notify the provider before it hits 30 days or 60 days or 90 days and the claim gets denied, right? It allows that kind of dialogue to take place between the plan and the provider more quickly, again, more expeditiously, more accurately with the LOINC codes. So the provider knows exactly what to do, when to do it, and to help remove that pend before the claim gets denied. And then it comes back on the remit as a denial. Then they have to go through the whole G&A process, right? So it's a way
Right.
to work the revenue cycle between both sides of that equation. So it's not as contentious, right? That's the whole goal here, is to work that revenue cycle process as cleanly as possible without tension arising because of a bad process, you didn't tell me, it fell into a black hole, with an acknowledgement and with interrogation of the attachment and communication back, all relatively quickly, right? It may not be in real time, although the core operating rules do support real-time submission of these transactions. It allows you to work with your provider community better. So that's what I heard too from what you just said, that you're working with the providers as they're submitting their data, and you can inform them when things are not working, and then they can rework it quickly.
Right. And sometimes what happens too is if it comes in and let's say it's an unsolicited document, somebody just sent it in, they're expecting us to match it to the claim. Maybe we didn't get the claim. Sometimes, as we mentioned, we have vendors that might send the attachment before we receive the claim,
Yeah.
before we get it out of their system. So we have it. And it's like, okay, what do we do with this? We hold it for 7 days in our system. And we wait for that claim to come in to match it up. So we know it right away when that claim comes in, it has an attachment with it. If it doesn't, then we just put it in our system and we just hold it. You know, at that point, then somebody that has the claim, if they're trying to say, oh, we need this documentation, hopefully they would look in the system and say, oh, it's here. It just
Yes.
came in earlier and that we've got that in our system. So we do save it and we hold it, but some are orphaned because sometimes we never get a claim.
Yeah.
And we do have some orphans in there. Otherwise, we would have had to do a RFAI asking for the request for information back to the provider saying, okay, we've got this claim. And they'll say, oh, we already sent that to you.
Yeah.
And then we'll have to explain what happened sometimes because sometimes they don't match, you know, it's
And
been
it
a long
causes
time since
provider
we
abrasion.
received the
Yeah.
attachment, but we do hold them for 7 days trying to match them to make it a quick process.
Sounds
So-
like that is a potential future core operating rule, Crystal, that you can, right? It's a business process that really helps providers. And again, that mismatch is really the timing. We have some rules around timing for the 835 and the remittance advice and the payment. But this is another potential opportunity that there is a difference in time, especially for unsolicited transactions. The claim comes in through one route and the attachment comes in through a different route.
Correct.
So by definition, they're going to come in at different times. So how do we still match these up or reassociate them so we don't have to reburden the provider on requesting it again and again and again? And those processes that we often hear providers voice in that space. So like, hey, I sent this in for the PA, but now I have to resend in the exact same document for the
Yes.
claim, right? Or I have to resend it in. You removed the first pen from the claim from the documentation I sent in, but there's a second pen. I have to resend it again. I just sent it to remove the first pen. So there's
Yes.
ways to catalog that transaction, that documentation that comes in, so they can remove it can kind of remove the pen from all of those processes. The provider doesn't have to redo it over and over and over again.
Yeah, and that's where we were talking about too, structured documentation will come in, you know, in the future, very
Really.
important because we have a lot of that, you know, a lot of prior auths, you know, pre-authorizations are occurring. And a lot of that information that we already have, why are we asking again for a claim when we're already had that information and we get structured documentation too, very easy to share that
Yep.
with the other systems. So yes, very important.
Perfect. I'm going to move over into our next section of the presentation where we have a couple slides to talk about our findings that we have in a study that we've conducted with another national health plan. you'll see that it falls right along with some of the topics we just talked about, Crystal, and what this plan was attempting to do and implement the 275 transaction along with the operating rules. If we go to the next slide, you'll see that there were very specific objectives that we had in our study that we wanted to set up to make sure we could track the data through time and understand where the savings were, where the potential pitfalls were, where the challenges in implementation, either with the provider community or with the health plan itself, or with the trading partners, because they worked with trading partners for this implementation. So again, we were trying to drive at the adoption. We're going to see if maybe there was some policy information that would be derived from it, because some of this is related to savings and recommendations that we might have. If you're going to, for example, was it LOINC? Was a LOINC codes the issue? Was that a problem? We didn't implement LOINC codes. We just had a request for additional information with a statement in there, not a LOINC code. Did that cause problems with the providers? So you did want to identify some opportunities for enhanced automation. Again, that workflow is really, really important, especially for health plans, getting the claim and the attachment reassociated to the right associate at their location so they can work those pens. Again, a big thing on process alignment, ensuring that providers understand what the requirements are, health plans understand the requirements, because again, you're training your own internal staff at the same time that you're training providers and trying to match that up. And the last but not least, we wanted to measure the impact. What impact did the implementation of the 275 have for the health plan? And how did it impact their providers? Health plans also had some really important objectives to meet as well. They wanted to be a seamless integration. They wanted to automate as much of this process as possible. So anywhere where they had to drop down to a manual process, it was identified, and what kind of resources would it take to resolve those. Also, because they were implemented the 275, and again, like we mentioned the PWK segment and what data comes in on the attachment and how we match that up on the claim for that reassociation component. How did it help improve or enhance the claim accuracy? Did it help reduce denials, especially if it was an unsolicited transaction that came in and solicited 275? It really helps when they both come in together, so you don't have to wait for the request for the additional information. Then the provider sends it. You already lost probably 10 days in that cycle, or more, depending upon your adjudication cycle. Again, also part of the process was to speed up that claims finalization process to make sure the claims get paid more quickly. Again, we can go to the next slide. You'll see some of the results that that was part of this. Again, the workflow is really important for the plan because this is a whole new thing that they were implementing. Before, it was really mail and provider portal processes, and now all of a sudden you're turning on an automated 275 receipt and workflow process. So providers submitted claims electronically using the 837 or manually using the HCFA. So the non-EDI claims were converted and submitted via web portal. There was the process for identifying the attachment type. Again, that ACN that Crystal mentioned, that's so important to ensure that there's that uniformity between claim and attachments, helps for that reassociation so much. Again, the attachment submission, they were submitting the 275 or uploading it through a fax or mail. Again, those never were turned off. They were just expanding the options for providers. Integration and error handling was also really important because, and I think as Crystal mentioned, identifying errors in the 99 can be really helpful for providers. If you can let them know much more quickly when there's a problem with the transaction, they can rework it. They rework it before the claim is denied. Updates and acknowledgements, again, there was no need to resend acknowledgements for voided or replacement claims. That's the process they chose. Acknowledgements were through the 99 and the 824. Lastly, the automation optimization component, the workflow was automated with the ACN scrubber, and only clinical review remained manual. So they were able to completely automate the receipt of the claim, obviously, and the receipt of the 275, and match them up and then deposit them for that manual review. So it makes it much easier to handle the entire onslaught of attachments that this particular health plan needed to process their claims. I think the not surprisingly, there were some key metrics and results that were really important in the study. And on the next slide, you'll see that they were able to increase during the time of the study, which was from the second quarter of 2022 through the fourth quarter of 2023, from one trading partner to five. They were able to add, right, and bring on different trading partners like clearinghouses and like larger organizations that submit these transactions on behalf of the providers. So it expanded their footprint for their providers. So more and more providers could submit. They had a 55% cost savings in reducing the costs associated with EDI versus manual. So it's significant savings for the plan. And over 90% of the claims they were able to reassociate, which is significant compared today with what you can imagine is a paper process. When the mail comes in with those attachments and they're being scanned and manually OCR'd and trying to match them the good old-fashioned way. So again, huge increases in EDI transactions from 8% to 24% in just 2 months. I'm sorry, in just 2 years or 18 months during the study. So this is a significant increase in just 18 months. Manual transactions decreased almost in half. And the web portal increased again from 29 to 38%, which I would still count as a win because providers are using the portal to resolve some of the issues that were received with the notifications, the error reporting. I think, Crystal, that you mentioned is really important. They can jump into the portal and fix and adjust and make a change versus starting all the way back over at the manual step or manual process. Given process improvements, faster turnaround, fewer errors, and a higher matching rate for accuracy. So the plan had significant success with implementing the 275 transaction with the 837 transaction. And again, this plan is continuing this process and rolling it out to more and more trading partners and more providers to see increased numbers throughout 2024 and 2025. With that, I know we have just a few minutes left. I'll open it up for any questions that we have from our audience. If you have any in the
There was one in the chat, and I just responded to
Okay.
Doug on it. He was talking about the APIs, the CMS API regulation, which I think he's talking about CMS 0057F, but I'm not sure. So I'm asking him that question. I sent that back to him, and how or if that overlaps with this work. So I'm just trying to get a clarification. I know the APIs are tied to the burden reduction work that's being done via HL7, a little different than this. But again, attachments can be used for prior authorization through a 275 if needed to process that complete prior auth, or also can be used with another process through HL7, a clinical data exchange. So in a way, yes, but I'm not sure really the 275 ties into those APIs. If a provider wants to use the API, I guess, and submit a 275 that way, they could. And we're all going to have to be able to support the APIs next year. Same with the clearinghouses. So I think your answer is yes and no. We will be supporting them, but not necessarily will the 275 be just submitted through an API.
I think that I'm not sure how to say this. I would say that for the specific use cases for the requirements under the CMS APIs for prior authorization, the EPA. Again, it's kind of segmented the industry because only specific types of health plans are required to implement, right? Medicare, Medicaid's, Medicare Advantage plans.
A
CHIP
lot of us
plans.
are doing all of it too, not to burden the providers. So you were
Right.
going to do it all for all
Yep.
lines of business. So it's important that providers are aware of that too. There's many payers doing that to keep it in alignment so they don't have that burden
Yep.
of doing things differently.
Yeah, for your commercial members versus your government-based plan members.
Right.
Yep.
Yep. And again, just so everybody's aware, I know there's other questions coming out. What payers are accepting 275 with 278? I think there's quite a few still doing that or are doing that. I know we are doing that. I can't speak for everyone, but maybe Bob, you have a better view of that. But one thing too, you can always go out to a payer's website And we have what's called companion guides or companion documents that will tell you what we're doing with 275 or any of the HIPAA transactions.
Yeah, I know that it has been a challenge. I think from the work that we've done and studied is that it has been a challenge for plans to implement the 275 for the 278 because their implementation of the 278 is also lacking. Right, and make a really robust process, you need both. You need to have a really robust 278 process, receiving those in, adjudicating them, requesting additional information. And it's just been the one that has almost been the red-headed stepchild of the X12 transactions. It has not been implemented well, although the transaction itself is really robust. It allows everything that you need to process a real-time 278. It's the implementation components of that. So it's the same thing with the 275. Many plans have not implemented the 275 to the robustness that it is allowed within the standard itself. So the standards are really robust. It's the implementations. A lot of that is driven by business need. I think we've seen over the course of the last few years that prior authorization is a huge business need. So how do we make that process really important to health plans and to vendors and making sure that we can automate that as much as possible? So I think that's why we've seen this drive towards the EPA with regulation because prior authorization is so important. But swinging back to claims for the 837s, that is still kind of a batch world for claims. They're still adjudicated in batch, not every night, even at your health plan. Sometimes they only adjudicate 3 times a week or once a month, right? Every plan has a little bit different adjudication cycle. So the batch process really accommodates the 278 transaction as well because you're trying to match up. I submitted my claim in a batch. I'll submit all my 278s in a batch. So it can be automated by batch, but know that the technology exists. It's been around for 20 years to submit all of these transactions in real time. Now, submission in real time does not mean that it is actually adjudicated in real time, but it can at least be received in real time. You'll know within 20 seconds or less, again, one of our infrastructure rule requirements, that whether the transaction was received, it didn't fall into the black box. You know that the attachment was received by the plan. It can be reassociated effectively, and the claim pins can be removed, and the claim can be adjudicated. So it's all really important processes, whether batch or real time. Another distinction, and Crystal, maybe get your opinion on this too, that oftentimes for the 275, I would see it as we need the medical note, we need the discharge summary report. It's a stack of data, basically, data elements that are coming in for the plan to adjudicate, evaluate, and adjudicate, versus perhaps with a fire transaction, you might be looking for 1 or 2 pieces of discrete data within the record versus the entire record. Or maybe you're looking for you're doing a hip replacement and you need the CT scan of the hip. Those might be more easily exchanged using a fire type transaction or model versus a 275 model. Both accommodate both, but it might be the use case that's going to drive the approach that the plan or the provider might take.
Yeah, that's correct. I'd agree with that, Bob. There's a lot of work being done in HL7. For example, if you have a HEDIS measure, you need an A1C, that piece of data, you could just do a quick request through clinical data exchange and get that right back from the provider.
Right.
But yeah, there's a tons of different use cases being worked on because we understand claims and authorizations are not the only thing, right, that we need documentation for. So there's a lot of different use cases, but that's for another time. We're talking about the 275 right now, and if you have any other questions, please feel free to drop them in our Q&A.
And I think we have to jump over to our call to action. So maybe I'll hand the call back over to Michelle for a comment from X12.
Thanks, Bob. Appreciate it. Great session today. And definitely, if we could go to the next slide, a couple of things we need to address. If you're interested in joining, becoming a member at X12, feel free. X12.org was a source of information. Also, if you're interested in participating in any of our standing meetings or interim meetings, all that information is currently residing at X12.org. If you need to submit any type of request for information, that is also located at X12.org. Next slide. Also, we're listening. We hear you. We want your feedback. And please feel free to go to x12.org feedback and let us know what resonated today with you around the 275 from an X12 perspective. Again, X12 is interested in hearing, listening, and getting your feedback immediately. Next slide. Bob, I'm going to turn it back over to you. Thank you, everyone.
Thank you, Michelle. And again, as we close out this afternoon, I wanted to also have a call to action for you. If you're not currently a core participant, or if you're a participant, but you've been maybe lackadaisical with that participation, we'd love to have you back or love to have you join and become that core participant. Because I think as you saw with the dialogue that Crystal and I had today, that the problems that providers have and the problems that health plans have, it's best when we air that dirty laundry and can share those pain points. And when we do that, we can have really informed discussions and pull the transactions or the standards that we need to resolve that use case with operating rules and kind of resolve a lot of the problems that exist with data exchange. And again, that really is helpful for that dialogue. So I think another important component of that is that once you build the system, it's great to have it validated. So we do have a course certification process that allows you to become course certified. And that's not just for vendors and clearinghouses. Many of our health plan participating organizations are also certified. They complete certification to make sure that the data that they say they're going to send actually comes out of those systems and it makes its way to the provider. Even through their trading partners. So if the health plan uses an Availity or a Change or an Optum or any other vendor as their portal partner, make sure that it works all the way seamlessly through. Again, we've heard the providers, hey, I sent it to my clearinghouse, but they say the plan never got it. Well, certification helps resolve those types of problems as well. So it's not just the data within the transaction, but it's also that workflow and the connectivity that can ensure that full continuity of the data exchange. Again, as you heard from our study that we've conducted, and we're going to be posting that soon, so you'll be able to read the whole study. Many health plans and vendors participate in pilot initiatives with us. So I'd also recommend if you have a solution that you want to have the industry know more about, come work with us. We would love to run an ROI study. We'll tell provider community what works well with your system, with your applications, with your implementations of standards and operating rules, so that they'll be more apt to understand that your solution resolves a lot of their issues. Again, it might be really siloed, it might be really specific products. We've done some with just prior authorization, some with just the 275, some with claims, some with the 278. So come join us and I'll be part of those pilot initiatives. Again, be an advocate, come support us. And if you have any questions at all, feel free to reach out to us at core@caqh.org. So I want to thank Crystal and thank Michelle for their time this afternoon. Thanks, Jackie and Sarah, for helping support the presentation, and have a good afternoon.
Thank you.